Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions. This particular session we'll be looking at is part of the series on common complications of HIV infection in children and adolescents. And in this particular section, we'll be looking at the gastrointestinal or abdominal system. We'll start off just looking at gastrointestinal complications. So there's a whole range of different aspects of the gastrointestinal tract that can affect children with HIV. Commonly, our children would present either not feeling like eating or having difficulty in eating. Very important to always check the mouth for any aphthous ulcers, oral candidiasis, or other conditions that might make it painful or difficult to eat. Just as in our adults, our children can also get esophagitis of the actual esophageal tract due to candida or a range of different ulcerating illnesses. Abdominal pain is sometimes caused by the medication that they're taking or by different infections. We're going to look in detail at diarrhea and nausea and vomiting. GIT bleeding is not that common, usually caused by infective causes, such as your salmonellas and shigellas and sometimes CMV colitis. And then, of course, our children also vulnerable to hepatitis and jaundice due to a wide range of all the different hepatitis viruses, including viruses such as CMV, but also your difficulties with drug-induced liver injury. And we'll also look a little bit at that later on. So a common scenario that you might have in a hospital setting is a 9-month-old malnourished child who you've admitted with gastroenteritis, severe dehydration, and malnourishment. You manage to treat all these acute conditions very effectively, dehydration resolved beautifully, but the child is still having loose stools. Another scenario we often see is children who get finally referred to the doctor, and when you take a history, you can see it's been repeatedly seen at the clinic over the past months with recurrent or chronic or persistent diarrhea. So how do we think a little bit about prolonged diarrhea and how do we manage that? So let's just start off with the general approach to diarrhea. I don't want to spend too much time on this. I think this is very well familiar within your hospital settings. But an important decision to make when we see a child with diarrhea is whether we're dealing with acute diarrhea versus chronic diarrhea or persistent diarrhea. And often what happens is that there's a recurrent diagnosis of acute diarrhea, or the child's always managed like acute diarrhea and without actually shifting that focus. And we generally use 2 weeks as our cutoff point. Most acute diarrhea should clear very easily within a 2-week period. If the diarrhea is persisting beyond 2 weeks, we have to start thinking differently. In our differential of our diarrheas, very quickly, of course, our first question is always gastrointestinal infections, and this is very common in our children with HIV, even more so, and they're also much more vulnerable to a much wider range of different organisms. I'm going to add in CMV colitis there, although that's not usually a true diarrhea, but they might have blood per rectum. The second big aspect is malabsorption, especially your children with a very low CD4 counts, as your HIV virus has a direct effect on the gut itself and can actually affect the ability to absorb both medication and food. And then, of course, our drug adverse events, very important, such as antibiotics, ARVs, and of course, we can also include the antibiotic-induced superinfection. And then there's a whole range of conditions that might not necessarily be directly involving the gastrointestinal tract. TB abdomen and MAC can lead to diarrhea, but also conditions such as malaria, urinary tract infections, and of course, our otitis medias. Quick few points on acute gastroenteritis. Important to make that decision if we need to treat this patient as an inpatient or an outpatient, and of course all of the good practices around oral rehydration, which we will not cover in this presentation. Very important, antibiotics we would only consider if it's frank dysentery, and very important with children especially is to remember to exclude UTI in all cases of diarrhea, so do that. We need to treat any electrolyte disturbances that might have arisen. We obviously need to continue our oral feeds, maintain the nutrition. And then this very important point, for it's often forgotten still, the WHO has made very strong recommendations based on good evidence of the usefulness of zinc in both acute and chronic gastroenteritis. The dosing is fairly simple, under 6 months, 10 milligrams a day, over 6 months, 20 milligrams daily. So let us look at persistent or chronic diarrhea. So this is diarrhea that's lasting longer than 2 weeks. We've done all our acute management and the diarrhea is not clearing. And remember that chronic diarrhea in a child can be a massive contributing factor to both malnutrition as well as wasting, as the child is losing very essential nutrients on a daily basis. When we think of persistent diarrhea, all the causes that we mentioned in acute diarrhea can contribute, but there's two main concerns that come firstly into our consideration. And the first is that it might be due to a temporary loss of the lactose digesting enzymes in the gut. So especially if the child is looking relatively well, it might just be that they have developed a temporary milk intolerance, and giving very good advice regarding excluding products that might have lactose in them is very important. And then secondly, our biggest common cause for chronic diarrhea is probably going to be a gut infection. And as mentioned earlier, with HIV positive children, there's a whole range of different organisms that might be causing that. So let's look at a systematic approach to chronic diarrhea, taking this into consideration. So firstly, of course, we're still going to make sure our rehydration is sorted. Please check the electrolytes in the kidneys and make sure all of that is not abnormal, and make sure that our nutrition and our diet is keeping track to keep up enough nutrition in the face of this diarrhea. But more importantly is we now need to find out what is the cause of the diarrhea. We can't just keep on rehydrating, and we will not be able to manage this child properly unless we actually find a cause. So very important to send stool. We normally routinely ask for an MCNEs, parasites, Clostridium difficile if appropriate. But please highlight on the form that the child is HIV positive. The labs will then automatically look for specific organisms such as Isospora and Cryptosporidium in those children. In children, very important to send your urine for an MCNS, or at least to do a dipstick to see if there are any nitrates or leukocytes in that urine. And a full blood count can also give us an indication of the type of infection the child might have and the chronicity of the illness. And then our focus is going to be to try and find the cause. And if we do not find a cause, one must have a very low threshold to then refer these children to regional or tertiary units where they can do the necessary further investigations to try and establish the cause. So while this is all happening, supportive management, looking at hydration, nutritional status, weight gain is very important. And you want to aim to provide at least 110 calories per kilograms per day orally within 3 days, so that we can protect the nutritional state. Remember, it's going to take a few days to get your results back. It might take a little while to actually sort out this chronic diarrhea. If the child is less than 6 months, it means we're going to continue with exclusive breastfeeding. And if you're using a formula, to use one that's low in lactose. And if the child's more than 6 months old, we want to start them with feeds as quickly as possible, small meals regularly, and if necessary, nasogastric feeding. Zinc and potassium supplementation is still very important, but do not use antiemetics or antidiarrheal medication, especially in a child where you do not have a diagnosis. So when you get your stool culture back, there's a whole range of possible organisms that you might see. And the two there that I would like to highlight is Cryptosporidium and Isospora. Both are probably your most common contributors of a very large watery diarrhea patients with immunosuppression. Cryptosporidium we can only manage with ARVs, but Isospora responds very, very well to cotrimoxazole and can be life-saving in a child with chronic diarrhea. Campylobacter is not so common, and Giardia is very, very uncommonly seen in the Eastern Cape, and therefore all the use of metronidazole, blind use of metronidazole, is not really indicated in our children. Microsporidia one sometimes sees, and it's controversial how much it actually contributes to the diarrhea or if it's an incidental finding, but certainly if you do find it, it's worthwhile treating that with decent course of albendazole. Less commonly, we do also see dysentery in our children, most commonly shigella, but could also be salmonella or some of your other organisms. And this is the only case where antibiotics actually are indicated, and it's only when you have this very specific infection diagnosed on stool or very, very strongly suspected. And you will take a stepwise approach as per the EDL to manage these children. I did also just want to add in a little bit out of the Stepwise program for the Eastern Cape Handbook of Child and Maternal Health of 2015. This is a stepwise empiric protocol for the management of diarrhea from day 1 right through to day 14. So if you have a child where the diarrhea is not clearing up, and you can see day 0 and 1 and 2 there is focusing on your rehydration, and day 3 or 5 they're already changing to lactose-free feeds if not breastfed. But they do also look at the use of antibiotics, which is still quite controversial. And if you are considering antibiotics in the use of a child with persistent diarrhea, I certainly would discuss that with a consultant. You can see in the Stepwise program they're adding in gentamicin at day 6 to 8. They also mention that one can use metronidazole if you're suspecting Giardia, but as I've mentioned earlier, very rarely seen in the Eastern Cape. The other thing to remember is that stool samples often miss on one culture your organisms, especially in your very watery diarrheas, and it's sometimes worthwhile repeating stool cultures if you are struggling to actually determine the organism of origin. If your stool cultures have all come back negative, if you have done all of your basic lactose-free diets, and the child is still struggling with persistent diarrhea, you need to refer. At that point, it becomes important to look for other conditions such as CMV of the gut, very rarely even Kaposi of the gut. You can have herpes of the gut, and none of those conditions you are going to diagnose with the investigations within a district hospital setting. So let's move on a little bit and look at DILI, drug-induced liver injury. So let's look at a 4-year-old child diagnosed with HIV infection, malnutrition, and TB during a current admission. Started on TB treatment, and after 2 weeks on TB treatment, the mom's happy for you to start the ARVs. And in this case, we do a routine ALT. So in our children with HIV infection, we don't usually do ALTs, but it is something that is indicated if you've got a child who's both on ARV and TB treatment. And now we find that this ALT is actually increased. So is it significant? What could be the cause? And at which point do we become concerned about an increase in ALT? So let's just look at what are the things we're going to consider if we have a child on TB treatment or on ARVs and we notice that the ALT is increasing. And our first big concern is always a drug-induced liver injury. A lot of the medication we use, our TB medication, our cotrimoxazole, our NRTIs and in our NNRTIs, a lot of traditional medication can contribute to putting extra strain on the liver. And unfortunately, if we do not manage that promptly, can potentially be fatal. So second highest on our consideration would be anything that's causing hepatitis, an inflammatory or infective cause of that liver. And most commonly hepatitis B and A, probably C you will not really see in children. CMV, hepatitis and Epstein-Barr virus can also be potential causes. But also we often see ALT in our very sick children, so children with severe bacterial sepsis, children who are suffering from malnutrition. And then I've put TB iris in brackets there because although TB iris is a common phenomenon in our HIV children, first it usually increases the alk phosphatase and the gamma GT, and only much later might we see an increase in the ALT. So it's a bit lower down in our differential. So if we want to make a diagnosis of whether this is a DILI or we need to manage it at a DILI, we're going to use the exact same guidelines that we're using for the adults at the moment. Unfortunately, we don't have anything specific yet on children. And in the HIV Clinician Society has brought out an excellent guideline that was published in the South African Journal of HIV Medicine. And they recommend any ALT that's gone over 200, any ALT that's over 125 and symptomatic, so if the patient has symptoms of jaundice or vomiting or is unwell, or if the total bilirubin is more than 40. So, for example, if the patient has got an ALT of 160, but they're still asymptomatic, you could potentially watch and wait, even though the ALT is almost 3 times the upper limit, almost 4 times the upper limit of normal. So I'm not going to go in detail through the management of your drug-induced liver injury, and I would please suggest that you read the guidelines provided by the Clinician Society. But just to give you an example of how that guidelines are structured, they will look at the results and classify it as mild, moderate, or severe DILI, and give very clear guidelines on how you manage that. So I've mentioned earlier, if the patient is clinically well, the ALT is up, but it's still under 200, and the total bilirubin is still under 40, we're actually going to continue the TB drugs and going to continue the ARVs, and you will be repeating that ALT and bilirubin on a weekly basis until it is normalized, or if the ALT then goes up further, you will have to manage that appropriately. Where in our drug-induced liver injuries where the ALT is over 200, irrespective of what the bilirubin is doing and irrespective of symptoms, we have to discontinue the standard TB regimen. And if they start on ARVs recently, you would also stop the ARVs and you would put the child on a liver-safe regimen. They're using streptomycin there. We don't have streptomycin much available. We'll usually use amikacin or kanamycin, moxifloxacin, and ethambutol. And in children, you would certainly discuss these children with pediatrician to look at the specific management for the child. You basically then watch your ALT and bilirubin very carefully until they've completely settled down. The ALT is certainly under 100, and then you will have a stepwise reintroduction of your TB drugs. Generally in drug-induced liver injuries, we don't reintroduce PZA as that's your most likely cause, unless the child has been very ill and a consultant recommends that we need to retry that, re-challenge for the sake of treating the TB adequately. So now I would like to move on to something slightly different, a completely different case, and showing the challenges of diagnosing children with TB. So this is a particular little boy that is admitted. He's 11 years old. He has gastroenteritis, history with fever, sweats, diarrhea, abdominal pain. He's not been gaining weight. He's been worsening over the past 2 years, and he's not coughing. So it's very similar a little bit to what we've just been discussing for our diarrhea cases. And when you look back, you notice he's had treatment for pneumonia, he's had treatment for gastritis and thrush at the local clinic over the past year, but his condition is continuing to worsen. He's a paternal and maternal orphan, and you have very little past history. When you examine this child, this is a very ill child. He is feverish, but not particularly tachypneic. Heart rate is up. He's got severe wasting, but with no peripheral edema, bounding pulses, oral thrush with pallor of the oral mucosa, no particular lymph nodes when you examine them, a little bit of non-specific crackles over the right lower lung, and an hepatosplenomegaly that is not tender. So how are we going to manage this child? Now let's look a little bit at what comes back from our lab evaluation. So not surprisingly, the child's HIV positive. He has a very low hemoglobin of 6, but also a very low white cell count. A liver function is a little bit elevated, but very non-specific. Blood culture is not helpful. And we do an induced sputum, and the gene expert come back negative, and the AFB is positive. This particular case was actually done some time ago when AFBs were still sent routinely. And on X-ray, there's consolidation of the right lower lobe. Bactecs are still pending. That is for your culture for TB. So this is what happened with this child in hospital. And it's interesting, if we were to do it in our current setting, we wouldn't have done AFBs at all, and the gene expert would have been negative. But looking at a child like this, we are very concerned at this point of extrapulmonary TB. But when the sputum culture came back, it confirmed non-tuberculosis Mycobacterium after 13 days, and the Bactecs cultures finally confirmed Mycobacterium Avium complex, and his HB at this point was stable at 8.9. Important to note that it would have been very prudent, and normal good practice would have been treating this child as an extrapulmonary TB. but the child would not have recovered very well on the normal TB treatment. And we have to have a very high index of suspicion of possible other causes when children are not responding to their TB treatment. So we now have to shift our result. Unfortunately, our non-tuberculosis mycobacteria has to be managed differently than our normal TB. So let's just look a little bit at Mycobacterium avium complex disease. It's actually a complex of different organisms that can cause this, and it might be one or more of these different organisms, including Mycobacterium avium, Mycobacterium intracellular, or Mycobacterium paratuberculosis. And interesting to note that these organisms are within our environment, and it's not something that you pick up from another person like we do with Mycobacterium tuberculosis. And often these children present with a disseminated infection, and it's something that they've picked up from the environment, and so we rarely actually see it in infancy. The older they are, and the lower the CD4 count, the more vulnerable these children are. And we don't really see MAC in children with normal CD4 counts, the older children with normal CD4 counts. So this gives us an idea of our risk. And our children under 1 year old, regardless of the CD4 count, but by the time it's under 750, more often, these children are always vulnerable because of their poor immune systems. Between 1 and 2 years, the CD4 under 500. By the time they're over 2 years, you actually have to have a very low CD4 count to develop MAC. And when they're over a 6, it's similar to our adults. You have to have a CD4 of under 50 to be vulnerable. So what kinds of things do we expect to see that will make us suspect disseminated MAC? And this is very difficult. You'll see it's all the symptoms of many of our disseminated illnesses, particularly TB. But you'll have your recurrent fever, your weight loss, failure to thrive. They can have night sweats, fatigue, chronic diarrhea commonly. And I wonder how many of our chronic diarrheas, especially our children with TB and chronic diarrhea that die, we've missed the diagnosis of MAC. Malabsorption, often abdominal pain, either persistent or recurrent. And you can have lymphadenopathy, hepatomegaly, and splenomegaly. So this is going to be a very ill-looking child, and difficult to find the exact cause. So your lab will often see a pancytopenia, which we also see in our disseminated TB cases. And you can have very non-specific things. For example, you can have an increase in ALP, and we often see an increase in the LDH, but very non-specific. So how do we diagnose MAC? And this is where it becomes difficult, because you have to isolate the organism, either from blood or from biopsy specimens from any site that you can get it from. And then the challenge is that it also takes a while to get your confirmation back. So this is one of the reasons why, if you have a child that's very ill, you diagnose disseminated TB, and even if you've started TB treatment, to still try and make sure you get a sample off, be it from blood samples, urine samples that you culture, bone marrow if you can, FNAs, to see if we can actually find the organism. And every now and then there's a MAC might come up. The other challenge is that it might take several blood cultures over time to actually require a positive result. A single result that comes back negative does not exclude MAC. So how do we treat MAC? And it's very important that all of these children must be consulted with a pediatrician. They do not respond to the normal TB treatment. And we normally combine a minimum of 2 drugs, either clarithromycin or, more often now, azithromycin, as it is available these days. We combine that with ethambutol. It's great to add a 3rd drug if possible, and for that we usually use rifabutin if we have access, or one can use the aminoglycoside or ciprofloxacin. Again, you would do this only under a consultant's advice. And the treatment should not be stopped until the ARVs with a CD4 count that's over 15% for at least 6 months. And we want the TB bacterial cultures of this organism be negative for at least a year. And this is just lovely to show how well this child did on that treatment and how beautifully he recovered. So now, changing tack again, we've got a couple of slides on mucosal conditions. I'm going to have 1 or 2 slides just talk about the skin in HIV. The adult presentations and that we have on dermatology in the adults also covers most of the conditions in children. But the challenge with HIV is that your skin and mucosal conditions present differently. So if you have a skin and mucosal condition and it's atypical, or it's very severe or extensive, or doesn't seem to be responding to your treatment, or it keeps on coming back, then do consider an underlying immune deficiency. HIV often presents early on first with skin and mucosal conditions. And in our children, oral candidiasis is a very common pediatric finding in young infants. But really after a month, it's something that we shouldn't be seeing that often. If a child is HIV infected, then oral thrush and diaper dermatitis is going to occur among a large percentage of those children, with Candida albicans being the most common cause of mucosal and esophageal candidiasis. Our treatment, still nystatin, is still our gold standard in treating these children with oral candidiasis. But we might go on to fluconazole. We have a much lower threshold to go on to fluconazole if children are not properly responding to the nystatin treatment. And of course, if they've got esophageal candidiasis, you will be using diflucan as your first resort. So let's move on to something a little bit different. And this particular 3-year-old boy has been on ARVs for the past 6 months. He's been referred to you for poor weight gain, and his grandmother claims that he has a good appetite, but he really seems to struggle to eat his food. And when you have a little look in his mouth, you see the following. And this is a huge challenge in our children with HIV and is often not giving much attention as periodontal disease. So in children with HIV, gingivitis and teeth decay is certainly more prevalent, and that is partly because of the immune suppression, but also a lot of these medications that they are drinking twice a day, especially the syrups, have actually got quite a high sugar content to try and make them more palatable, and this can contribute to the higher incidence of disease. And then similarly as with the rest of our HIV negative population, we have a huge challenge worldwide, but also especially in South Africa, with sweetened drinks given to children, be that tea that's been sweetened or oros or juice, and especially if it's taken from a bottle. Children often eating treats that's high in sugar, and then of course poor oral hygiene. And one of the important parts for us as clinicians is to make sure that parents with children with HIV are very well counseled early on. Prevention here is absolutely key, and actually in the guidelines it's recommended that we have to refer to a dentist within the first year of an ARVs, all of our patients, for proper teeth cleaning, a proper checkup for oral conditions, and proper advice on oral hygiene. But we have to be realistic that we do not have those services available for our patients. And so the duty of discussing the health of the teeth actually falls with the nurse and the doctor. And it's up to us to be teaching good oral hygiene practices, to ask our parents about brushing of teeth and what they are doing with the cleaning of the child's teeth, also, for example, after giving the medication. So giving advice on limiting dietary sugars, no sweetened liquids, only water, and certainly nothing in a bottle. And also the importance that they need to rinse the mouth or ideally brush the teeth after taking that medication twice a day. It's also possible to use tricks such as using a syringe to bypass the contact with the teeth and to try and reduce the risk. So important to keep in mind and important to counsel our patients before starting the children on ARVs. Thank you very much to these wonderful slides, both from contributed from Wits RHI and Dr. Lizelle Keert, our DCST pediatrician from BCM. We've got one more part in the series that's going through a whole range of other conditions. Thank you very much.